Thank you, thank you. This is my very honor to my presentation. Okay, I already upload my data. Please start my presentation. Thank you for invitation for the great conference. I am Dr. Yutaka Hikichi from Saga-Ken Medical Center, KOSEIKAN, Japan. Today my topic is Japanese approach on bifurcation. This is my disclosure. Today's my presentation separated three parts. First is trend in Japanese PCI. The JPCI registry is the only one national registry in Japan. Japanese population is now beginning to decline gradually, and along with this, the total number of PCI cases has begun to decline after peaking in 2017. Until 2016, there were many PCIs based only on coronary morphological stenosis. However, from 2017, it became essential to probe not only lesion morphology but also physiological myocardial ischemia, which became a necessary condition for insurance coverage. Frequency of use of FFR has increased significantly. While FFR usage revealed to the total number of CAGs increased to 13% in 2017 and reached more than 25% in 2019. Due to the widespread use of CT machine in Japan, the number of the facilities that perform FFR CT is gradually increasing. As a new attempt, the method of measuring FFR from the result of normal angiography using an FFR angioanalyzer is also covered by insurance. Biggest merit of this device is that there is no need to reinsert the FFR wire after treatment. IBUS is installed in almost all catheterization laboratory in Japan, and about 80% of all PCI cases are used as routine device. The J-River study is one of the leading studies focusing on the treatment of bifurcation lesion using IBUS system. From this study, it was found that detailed observation using IBUS before expansion improves prognosis of bifurcation treatment. A valuable study showing the importance of using IBUS at the coronary bifurcation. Approximately 14 or 18% of all PCI cases use OCT or FDI. Observing using OCT or FDI has some advantage when complex stent implantation is expected for bifurcation lesion. With co-registration when performing measurement using OCT, it is possible to obtain a large amount of coronary information with a small number of examinations. For this result, determine the treatment, the method, stent placement method, stent length, and stent size to be used. We aim to end with the single stent method as much as possible. Approximately 82 or 90% of bifurcation lesion has been treated with the single stent method in current Japan. This is a bench model followed by left main bifurcation. If we implant 3.0 mm stent according to the diameter of the distal side and do not perform pot or kissing. The outer region where the stent strut that is surrounded by a yellow circle caused incomplete stent apposition. It can be seen that the blood flow dropped extremely. Furthermore, in the gel circumflex ostium, it is easy to see that blood turbulence and drop are occurring on the back of the strut. If we chose a 4.0 mm stent according to the diameter of the proximal side and even do neither pot nor KBI, the area of the incomplete apposition of the stent will decrease and blood flow reduction area will also decrease. On the other hand, in jailed circumflex ostium, it is easy to see that turbulence flow and decrease of blood as in the previous result. From these flow study results, we understand the requirement of stenting. First is eliminate incomplete apposition of stent. Second is reduce the deformation of stent on the main vessel side. Third is reduce the jailed strut at side branch ostium. If the stent is implanted in the main vessel and the guide wire is inserted from the distal as much as possible and the balloon is expanded only on the side branch, the main vessel stent will be deformed or moved in the longitudinal direction. Regardless of the stent design, the main vessel stent is elongated in the longitudinally when the side branch is expanded only. The most important principle is effective stent implantation for main vessel. Nevertheless, due to the side branch expansion only, the main vessel stent is deformed, which is difficult to repair. We can see that the strut on the distal side of the bifurcation of all type of stent were stretched from the distal side to the proximal side in the longitudinal direction. These results indicated the need of another effective KBI method to prevent longitudinal deformation of the main vessel stent. Here is a simple and effective kissing method. Inflate it at the same time or main vessel side first, about 4 or 6 atmosphere. In this state, increasing the pressure of the side branch balloon gives the ideal expansion result, like this, and it is necessary to consider a way to improve the long-term prognosis of the side branch with approximately side branch expansion. Drug coating balloon has been highly expected in Japan for the past few years, and the usage rate and total number of DCB used are increasing year by year. The effectiveness of DCB in bifurcation lesion need to be investigated. Recent meta-analysis of RCT does not confirm the usefulness of DCB when comparing the entire TLR. This meta-analysis shows efficacy of all-cause mortality and myocardial infarction for de novo lesion. It was also shown to be useful when there is a high bleeding risk patient, like Japanese. Analysis focusing on the side branch did not demonstrate the usefulness of DCB in the TLR and MACE compared simple balloon dilatation. It could not be shown to be useful for restenosis of the side branch and was useful only for late lumen loss of the side branch. Although this study target is not side branch, it has been reported that the combined use of scoring balloon and DCB in de novo lesion improved clinical outcomes, and this method is currently widely used for side branch in Japan. For the left main bifurcation, it is increasing that DCA is carried out with the IBAS guide for patients who are young and fit the condition. The image on the left is a DCA and the right is an IBAS after DCA. This is a final angiography. Here are the results of the DCA-DCB registry in Japan with a good TLR of 3.1% after 12 months. It may be one of the effective treatment for the bifurcation lesion. This is a result of an experimental model given by Professor Iwasaki of Waseda University. The normal bifurcation without a stent is shown on the upper left, and the model with stenosis shows the upper right. The lower left shows the classic crash stenting, and lower right shows the full model, provisional T-stent model. If you continue to observe in the bifurcation, you can see the lower video show the blood flow is slow, especially on the behind side of the new carina created by two stents comparing the upper model. Comparing the difference of blood flow with the color bar makes the slow blood flow part clear. So, which method can keep incomplete apposition low? TAP, curot, and crash are fundamentally different methods depending on which order to the stent are implanted first. In Japan, stents are often placed in the main vessel first, and curot is still the most commonly used, and the frequency of crash or decay crash is very low. Recently, we rarely use the two-stent technique. However, depending on the case, we also encounter situations where the two-stent technique is needed. We compared curot or decay crash. The left is curot and the right is decay crash. The part of carina painted in green shows the incomplete apposition. In the curot group, the green triangle shows the incomplete apposition volume in the carina part. In the decay group, compare the curot, decay crash or higher incomplete stent apposition volume in the carina. This is a high pressure group. Comparing the high pressure DK and curate, there is no significant difference in the ISA volume in the carina part. I didn't pay attention this time. I think that lateral wall incomplete apposition volume can be reduced by minimal overlapping stent and additional high pressure final pot. The characteristics of PCI for bifurcation lesion in Japan is the utilization of physiological study and imaging study. By utilizing these, it is aimed to at simple main-based stenting. It is exploring the possibility of scoring plus DCB or DCA plus DCB. The two-stent method has not been carried out only less than 10% of all PCI lesion treatment, and selecting the method aimed to incomplete apposition of the stent. Thank you. Thank you very much.